endoscopy session of the year, and I hope you're going to enjoy it. It's touching on aspects of training, which I think are very important for us to develop throughout the African continent. The meeting is hosted by the Gastro Foundation in association with Project ECHO from New Mexico, and we are with the hub in India, who are providing us with technical support. Sessions are held weekly, and again, there's a few more to go at the end of this year, but as I said before, this is our last session. We have 44 registrations from 15 countries, all over Africa, and including Belgium, which is where our other guest is from. And we look forward to you interacting with us through the chat, and we would please like you to post that and to try and make the discussion as interactive as possible. What we're going to do is I'm going to kick off with some principles about training and training the trainers. Again, it's a huge topic, but we're just going to try and cover some basics. And then we have the pleasure of having Vikesh Lala, who's a graduate from the gastroenterology program in WITS, who's just been over in Belgium doing a fellowship there, in which the foundation was instrumental in providing him with support to get there. And he's now back in the fold in the University of Witwatersrand GI unit. And we're looking forward to hear how he has got on, and hopefully reinforce some of the things I'm going to say, I hope. Anyway, with that in mind, I'm going to share my screen and start with my talk. So, are we the right way around, or do you have my slide view?
We've got your slide view.
You have my slide view.
No, you've got to put it in presentation mode for us.
All right. Yeah, all right. And now?
That's perfect.
Oh, okay. Thanks very much. So, yeah, I represent a few people, and some people would say I'm a Scotsman lost in Africa. And since retirement about 5 years ago, I've spent my time focusing on trying to improve standards of endoscopy training. It's my sort of, shall we say, retirement hobby. And so this is the old model. This is the very famous surgeon who started up surgery in South Africa, the first professor of surgery in Cape Town. And he actually trained in Newcastle in UK, near the Scottish border. And he did his postgraduate studies with a very famous surgeon called Rutherford Morrison, who, for those surgeons in the audience, is a gentleman who invented the incision to take out the appendix. As you can see, he worked as his house surgeon, his registrar, his private assistant, and then he came to Cape Town as a fully trained surgeon, illustrating how you have an apprenticeship in surgery in the old days. However, things have moved on since then, and I've sort of not quite as young as Vikesh, but I've had a lot of background in training and training the trainers. First started in ATLS, and then subsequently with basic surgical skills, and indeed with the WGO, both participating in and running Train the Trainers for their organization, which again is a program which has continued to go from strength to strength. And then we ran a Train the Trainers sponsored by the WGO in Wolverhampton, and that opened my eyes to the training situation for endoscopy. And subsequent to that, we did the Train the Trainers in Cape Town, a couple of them related to colonoscopy and ERCP. This first picture on the left is the whole mob that got together from all over the world, and we were very grateful to that. There are a couple of my colleagues sitting there, and they realized their deficiencies, not in being able to do colonoscopy, but being able to teach it. And these are pictures from our session that we ran in the unit at Grooteskier some 7 years ago now. We've sort of bought into the JAG and JET system, and I'm sure you're going to hear a little bit more about that from Vikash, but that's basically their system that advises on endoscopy. And they have in the UK some 14 centres that are the training centres for all trainees. And they have a national database that records the key performance indicators. So what is competence? We have to start with some actual description. It's the minimal level of skill, knowledge, expertise derived through training and experience to perform a task or procedure safely and proficiently. It sounds pretty simple. And let me tell you that no traits are possessed a priori. Some may be born to become an endoscopist, but no one is born to be an endoscopist. Similarly, no traits are possessed a priori to become a trainer. No one is born to become a trainer, and you can learn to become a trainer. And again, we hopefully will expound some of the principles of how to do that. And of course, these are the various stages of how you go through your journey in training. And again, we want to aim for someone to become proficient and for some of us to become experts. I would consider myself proficient rather than expert. And again, to become an expert, you have to practice and you need volume. I want to spend a little bit of time talking about this diagram, which many of you may have seen before. And I want to sort of just illustrate how that's very important when you're teaching a skill, and as a trainer, how you must sort of take in this cycle so that you can teach properly. So you can see we go from unconscious incompetence to conscious incompetence, conscious competence, and unconscious competence. That's the expert who doesn't need to think about what he's doing. He just does it, just like expert footballers or expert tennis players. But you must beware of some individuals, and this is called the Dunning-Kruger effect. It's a metacognitive inability for those of low ability to recognize their ineptitude and evaluate their ability accurately. You can see they're at the top of Mount Stupid, and their learning curve, again, is very different to what I'll show you in a minute. I'd like to illustrate one situation that I got myself into with my daughter, which illustrates conscious and unconscious incompetence. I took the car out with 2 dogs in the back, and my daughter, who, as you can see, was learning to drive, and I left the car in full lock. She jumped the clutch and almost put us over the wall. And of course, whether that was her fault or my fault as a trainer, I leave that for you to decide. But it was quite an experience. So hopefully you've realized that incompetence is not something that we desire and that we need to be aware of. The other way that you can interpret that journey from incompetence through to mastery is to look at it as cannot do, can do with instruction, can do without instruction, and can write the instructions. So I want to just elaborate on that a little bit more. And we need to remember that even though, generally speaking, we think that the psychomotor aspects of doing a procedure are the key, we need to know that we have to have cognitive and affective skills to be able to do endoscopy. So we mustn't lose sight of that. So this is the sort of agenda for the TTT. And again, in the old days, this used to be set, dialogue, and conclusion. And we can just change the words and call it preparation, training, and wrap-up. And at each of these stages, we are still in the same process of reflecting on how we're doing and exactly what we're going to teach the individual through the procedure. And we'll talk about some of the things that are mentioned here, the agendas, about learning objectives, about feedback, cognitive overload, and again, trying to get into the habit of giving performance enhancing feedback. So this is a typical diagram of showing you where you reach competence, and that's the dotted line across the top. Below that, you're incompetent, and your trainer is trying to get you across that line as quickly as possible. And it's important that you realize that you and the trainee must have the agenda aligned. You can have an overall agenda, which is to allow you to be competent at colonoscopy. But his common mistake is that during the first episode, he wants to be able to reach the cecum. And you know that you're just going to have to teach him aspects of that journey in the first visit, and that you're going to focus on how he handles the scope and how he steers it through the first corner. And again, we really rely on this sort of concept that you're going to set a specific goal, you're going to see and help him through that particular goal in endoscopy. You're going to do an assessment, and you're going to do reflection on his appraisal of his performance and your appraisal of his performance. And then you're going to set the next objective for the next visit. And hopefully we'll see some examples of that. And one thing a trainer should be, he should be an expert. You have to be competent to be able to do the procedure. You need to be able to deconstruct the task. You need to be able to narrate the task. You should be able to not always take over the task and able to hand the task back and enable performance enhancing feedback. You'll get that a lot. So this is one way that you can put the instructions and be able to deconstruct the task. This is from a cartoon, and you can see this is how you must do things. You must do step 1, step 2, step 3, and eventually step 4. And again, if you can describe the procedure in those steps, then the individual is likely to be able to perform if you give him the correct instructions. And again, I come back to the performance over time, and you can see how you can try with structured training to shorten the time and the numbers needed to get to the level of competence. And again, you obviously want to be attaining and aspirational to get right up to the top, which is the expert or the best. But remember, there are lots of things. This is from any sort of basic endoscopy, because now endoscopy is an interventional sport. And you can see the various different aspects that an individual who's doing endoscopy has to master, and they will master them at different in different time frames, and they will master them sequentially for some of the aspects that we're talking about. Again, it's important that we talk about all the domains, the technical, the visuospatial and tactile, because we have to interpret the images. We need to communicate with our nurses. We need to determine what's pathological and what's variations on normal. And we need to make good judgments in the endoscopy room about what to do and decision making. We need to talk about language. And again, many individuals will have different trainers. And again, we need to be very consistent about how we describe the things that we're going to tell the individual to do with the scope. And again, we prefer advance, withdraw, insufflate, deflate, stop, which is a very key thing to get into your trainee's head, that sometimes he has to stop because he's dangerous. Tip up, tip down, tip right, tip left, and torque clockwise and anti-clockwise. We should use those terms as the consistent terms. Again, you can decide within your own faculty exactly what those consistent terms are. The next thing that you want to do is to avoid cognitive overload. That is the trainer who talks all the time, who talks different language all the time, and who doesn't realize when the trainee is in trouble, so he keeps talking to try and get the trainee out of trouble. When the trainee stops talking and you can see his hands are contorted, you should stop talking and stop and have a reflection on what the problem is and how he might proceed. So again, there are those things to avoid. And just to illustrate that a little more, these are some of the ways that you can look at it. There's the intrinsic load. And again, our working memory can only manage a few things, especially when we're looking at manual dexterity issues. And again, when it becomes overloaded, the learning and performance suffer. And again, you've got the basic intrinsic load, and you want to get rid of the extrinsic load, which includes the trainer on occasions. And then there's the germane load, which is actually what the training episode is about. Again, to come back to the goal setting, and again, these are very jargonese educational terms. They must be specific, measurable, achievable, relevant, targeted. Again, you only can come to these when you do a train the trainers session and you start to appreciate exactly what these words mean, these educational speak means. Again, here you can see us. We are now in a training episode with somebody trying to train someone in the Koken model to try and maneuver the scope and keeping the lumen in view. And again, that's a training episode. Here, the same episode is in the room. You can see the nurse, you can see the trainee, and you can see the trainer on the right. Some of you may recognize Brendan Bemington from who was being trained as a trainer during this, from WITS during this period. Again, we come back to this diagram that you'll see a lot of. You might see it again from Vikesh. And I want to just talk a little bit about feedback. And again, remember that feedback can be helpful or detrimental. And again, surgeons are notorious for giving detrimental feedback. They expect their trainees to walk on water before you teach them. And again, feedback is very key as to how you do it and how that individual reflects on it. And you want to really improve the fellow's ability to achieve his potential by using performance enhancing feedback. And you must remember that it's not just about your performance with the scope. It is about how you sort things out in the room, how you interact with the nurses, how you make decision-making, which are definitely non-technical aspects of what you should do. I just want to say a little bit about assessment and how most of the world has moved to directly observed criterion based assessments. The name for that in the UK is DOPS, but there are a variety of different ways that you can do it and different acronyms that have been devised. But essentially, I just want to say a little bit about DOPS. Again, it's a valid workplace assessment tool. You can use it for feedback. It reliably assesses endoscopy skills and can be used to certify competence and also to recertify competence if you fall below the mark. And again, what they do is for each of these categories that you see there, assessment, safety, endoscopic skills, diagnostic and therapeutic ability, you want to get to the key there that the individual can do it without instruction. And if you decide after direct, and again, here are some of the ways that you can get that exact criteria reference for each of the skills that you're expecting the patient to do. And again, you're going to categorize these as can't do, can sort of do, can do with instruction or with very minimal help, and then can do with proficiency. And again, eventually that score comes up and you have to score 3s and 4s, and you also have to have a global assessment. And again, if you do this over 3 things with two or 3 different experts assessing you, you can be pretty sure that the individual is competent. This is a way that they do it in Holland. And again, here you can see that the subjective assessment is being done on a visual analog scale, and there is an improvement plan. Again, this feedback for the next episode of training and how you want to progress with your learning and improvement with your skill set. So these are some of the concepts. And of course, then you can measure what are called KPIs. And here I show you some of the KPIs for colonoscopy in the UK. And again, we need to have a cecal intubation rate of 90%, an adenoma detection rate of 15%, and a withdrawal time, most people would say, especially for a trainee, somewhere around 8 to 10 minutes. And again, these can be measured. And I'd just like to put into perspective, this is some information from JAG, who monitor all the trainees in UK. And you can see that to achieve that 90% competency at reaching the cecum, that takes about 233 colonoscopies. And again, here you can see, if there are those of you who are remember the baby charts, if you have any children, where the middle one, the black line is the middle, the 50 percenters, and then you can see how you can map your performance if you can map the cecal intubation rate. And you can measure other parameters that can be considered as key performance indicators, like the time to the cecum, as you've seen before. So these are important to remember, that you shouldn't leave the trainee alone in the room, certainly for the first 20 colonoscopies, because he's unlikely to have a very high success rate. And again, we come back to the whole business that this is not just about psychomotor skills, it is about the other skill sets. And it's not just about the doctors, it's about the team. I used to watch Grey's Anatomy, but I think that was all about the doctors. But it is about the nurses, because they are the sedationist, the snarer, the bander, the needler, the stenter, the wire passer, and they're essential to you doing it. And they're not the only essential member of the team. You have lots of others who are key to the successful outcome of your procedure. So my take-home messages are that no one is born to be a trainer. There are some principles that we've sort of discussed, and I hope you've taken heed of them. All learning domains are required. Deconstruction and narrating the task is key. Setting objectives and reflective feedback enhances performance. It's a team effort. And I really do believe that we need to develop within the countries in sub-Saharan Africa and Africa that a culture of being able to train using some of the modern principles that have been espoused, especially by the surgical and JAG teams who have taken these training principles forward and put some science behind them. So with that, I'm happy to take any questions, but I think it probably would be best for you to post your questions, and then Vikesh can give us his feedback and his take on some of what I've been saying. I haven't had the pleasure of training Vikesh, but I'm sure they have in Belgium, and I'm sure he's learned a lot. So we look forward to hearing from you. I'm going to stop the share, and please carry on, Vikesh.
Thanks, Prof, for that kind introduction. And as you mentioned, for those that don't know me, my name is Vikash. And I had the privilege of doing an advanced endoscopy fellowship in Europe, in Belgium. And I'd like to just share some of my experiences with you today and share some of the crucial lessons that I learned and I think we can all benefit from. So that's just an overview of the talk. I'm just going to briefly start by sharing a bit of my experience. So I qualified as a gastroenterologist a few years ago, and I've always had a passion for endoscopy since early on in my training. I would always watch these videos and these online contents of people doing all of these advanced procedures, and I'd always be in awe of the new procedures, new technologies, new developments in the field. And I always had a passion or the dream of being one of those people performing those procedures in the videos. My lucky break came in 2019 when I was fortunate enough to attend the UEG week. And that's where I attended one of the networking sessions, the Young GI section. And that's where really things just opened up for me. And like I'm saying, I consider it a truly lucky break. So at that session, I met Dr. David Tate. He's an interventional endoscopist in Belgium, in Ghent, who was trained in gastroenterology in the UK and subsequently did an advanced endoscopy fellowship in EMR and other procedures in Sydney with one of probably the world's leaders in polypectomy, Michael Burke. So we began chatting, and the end of the discussion basically led to the ability or the possibility of joining him for an endoscopy fellowship. So there I was, filled with hope, my dreams possibly coming through and filled with enthusiasm. But unfortunately, I faced a number of challenges. And shortly thereafter, a few months later, we know COVID-19 was declared a pandemic, and that put my dreams to basically a grinding halt. I faced a number of challenges over a lengthy period of time, which I needed to overcome in order to get across COVID-19, financial challenges. I had to self-fund, so I sought funding opportunities from industry as well as from the Gastro Foundation. I saved up leave for that as well. I then had to get academic recognition in Belgium in order to practice there and do hands-on training. And it was also quite a cumbersome process trying to obtain a long stay or work visa. I also had certain challenges with language barriers. However, a bit of knowledge in Afrikaans did certainly help with my Dutch. And I managed to overcome those challenges thanks to this group of lovely people. And I really couldn't have done it without them. But special thanks to Professor Adam Mohammed, Dr. Neo Sihabi, and of course, Dr. David Tate. So there I was 2.5 years later, after persevering, after almost giving up many times, I found myself in the beautiful city of Ghent at the UZ Ghent Academic Hospital. And I was fortunate, during my time there, I was able to join their annual symposium, Geeks 3. And this was truly a world-class symposium. And it gave me the opportunity to meet some true international leaders in the field, the likes of John Anderson, Roland Valery, Michael Burke, Ralph Bishops. And I got to present alongside these true leaders and interact with them, which really did open up my mind to the possibilities of what's available out there. And after a period of quite intensive training, after a 6-month period of training, I was able to achieve certain things. And these are some of the achievements I was able to perform. So you could see I was able to do some EMRs, so quite large polyps, SMSA4, SMSA plus polyps. If you're not sure what SMSA polyps are, I'll allude to that later in the talk. I was also able to achieve competency in some of the advanced endoscopic procedures. On top, you can see some images of a POEM, esophageal POEM. In the top right, that's an image of a sphincterotomy for a GPOEM, and you can see some images of an EST at the bottom. So as soon as I got back, the first question that people started asking me is, do you have any tips for us? How can we become polypectomists? How can we take out big polyps? What can we do? So I decided to dedicate the bulk of my talk to that. Unfortunately, I'm probably going to disappoint a lot of you, but hopefully I can convince you that it really is in good basic technique. And hopefully through the course of this talk, I can change mindsets. And I truly believe that in order for us to uplift endoscopy in South Africa and Africa as a whole, this is something that we really need to do. Perhaps changing mindsets is not the word I should have used, rather opening mindsets. So how do I attempt to do this? So I'm going to try and give you some practical tips. And the reason why I showed you some of the pictures of some of the things I was able to achieve is because I truly believe I was only able to do so because of having sound knowledge of basics. I was quite fortunate. I had quite good trainers during my early training as a gastroenterologist. And that combined with virtual tools such as the Gleeks platform enabled me to achieve core competencies. And I truly believe that I wouldn't have been able to achieve half of what I did across at Kent if I didn't have sound basics. The tips that I plan to share with you are rather concepts, and they're globally applicable. They need little or no resources. They're applicable to trainees, trainers, pediatricians, endoscopists, surgeons across all levels. They're sustainable. So, and they present what I think a paradigm shift in the way we think about endoscopy. So I intend to share some concepts with you and back them up with some practical examples. So the first concept is you don't know what you don't know. And this is a hard lesson to learn, and one I certainly had to during my time in Belgium. Problem is, a lot of us think we may be competent in certain procedures, colonoscopy, polypectomy, for example, but we truly don't know what we don't know. And the only way we can achieve this is by auditing ourselves and by assessing and doing quality surveillance. So before you can move on, before you can learn, you need to identify what you don't know. And I'm going to run through the following slides quite quickly because Prof Thomson alluded to the JX system already. But I'm going to try to show you some lessons learned from the UK, which illustrate the point of quality assurance and gaining awareness of what we don't know. So you mentioned the Joint Advisory Group, or the JAG group in the UK, which has defined standards for clinical practice in endoscopy across various platforms. So they aim to provide quality to trainers, to trainees, as well as to institutions which train people. And this is a quality assurance measure which is continued and also uses a system called the JETS to enhance the training component. So as you can see, it's quite a lengthy process to achieve accreditation in the UK in order to practice independently. And Prof has already mentioned the DOP system and the DOPS-Y system. That's essentially directly observed procedural skills. So again, here the focus is on quality and not pure numbers, directly observing skills and assessing someone as being competent. And that does not equate to volume. Having done 200 colonoscopies does not mean you have necessarily achieved competency. So you can see, in order for a site to achieve accreditation as a training site, they have to go through quite the strenuous process with site visits, annual accreditation, and follow-up visits to maintain the accreditation. This is also enhanced by the National Endoscopy Database in the UK. And this is a system where data is extracted from every endoscopy report from over 400 centers. And this is put on a central database. And you can see it's a high volume of endoscopic procedures. It essentially allows every endoscopist to access their own data. So you can access your own KPIs on the system. Heads of units can access the data of people within the unit, and researchers and people doing quality assurance can access the entire database. So does this actually improve endoscopy? This is a paper which was presented in abstract form at UEG a month ago, and they used the NED system to assess quality parameters in colonoscopy. You can see about 600 colonoscopies, almost 4,000 endoscopists. And essentially what you can see is that all parameters significantly improved from the initial audit in 2011. And this to me is a good measure of the impact that the JAGS and JET system has had. Just another example of quality assurance is something like adenoma recurrence rates. And I think this should be a KPI for polypectomists. So we all may think we are able to take out the polyp. We all may think, what's the use in spending 2 hours maintaining good technique when I can simply whip the polyp out in 30 minutes? But the question is, do you really know your adenoma recurrence rates? And you can see rates vary quite widely in the literature, from 55% to a large meta-analysis which showed 13.8%, to the Sydney group with Michael Burke, who reports rates of 1 to 2%. So there is certainly something towards technique, and this points towards it. So again, if we don't know adenoma recurrence rates, if we don't know how to do a high quality scar assessment after removing a piecemeal adenoma, we aren't aware of that big black hole, and we simply don't know what we don't know. So these are some of the limitations we faced in South Africa and Africa, and we lack national screening databases, we lack screening colonoscopies or FITS tests. We have lots of resource limitations, but I do believe that this should not be an excuse to strive for quality. I believe that simply auditing ourselves by means of simply keeping your data in an Excel and looking at your own KPIs is something that easily any of us could do. So how do we overcome some of the limitations in Africa and in South Africa? I believe our focus should be on training. We should aim at standardizing training. We should focus on quality rather than quantity before we assess competency. We should use assessment tools and a variety of platforms like symposiums, courses, and virtual platforms. This is where I'd like to introduce the Geeks Foundation. So this was co-founded by David along with some of his colleagues from the UK. And it's really a platform which strives to promote safety and quality in everyday endoscopy practice. The URL is simple, it's geeks.com. And I urge you to have a look at it. I certainly have benefited tremendously from the platform, and I do believe it's a valuable tool that we can all benefit from. So again, I think Prof already touched on the concept of conscious competence. What is consciousness? It's having awareness, showing realization, and it's showing intention. So I would somewhat argue against some of the things that were mentioned earlier. So to me, conscious, or we all start off with the procedure being unconsciously incompetent. We don't know we can't do the procedure. We very quickly learn that we don't know we can't do the procedure. But the problem is the bulk of competence then achieved unconsciously. And this is done by pure volume. And this then becomes an issue. And I'll illustrate a little bit in the subsequent slides why this becomes an issue. So the majority of people attain competence purely by volume and not by consciousness. So they bypass the conscious competence component and move straight to unconscious competence. So what is conscious competence? So when you're sitting in the colon, you're doing a colonoscopy and you're faced with a loop. For me, conscious competence is simply the what, how, why, when, and who of any sort of endoscopic procedure. So you're dealing with a loop. You need to ask yourself, what is the problem? Why can I not proceed? You then need to ask yourself, how do I overcome this problem? Do I turn the patient? Do I apply torque? What are the techniques do I need to overcome the patient, the problem? You then need to ask yourself why. Why did what I did work? And more importantly, why did what I did not work? You have to ask yourself when. When do I turn the patient? When do I apply this a certain degree of torque to overcome it? And you then have to ask yourself who. So in which patient will this work? Is it the patient, the elderly person with chronic constipation and lots of diverticular disease in the sigmoid? So these are some of the problems with unconscious competence. It leads to longer learning curves, poorer patient outcomes, longer procedure times, because you often have to try a few different techniques before you come to the solution. And to me, one of the big components with unconscious competence is an inability to effectively train. So a classic example of this is the trainee who's doing a colonoscopy is stuck with a loop, and the trainer is attempting to take him through it. The trainer eventually realizes that he can't and has to take over the scope to feel the scope. And I'm sure we've all done this, or we all have done this to someone, or have it done to ourselves. And the trainer then takes over the scope, feels, tries maybe 1, 2, 3 things, and eventually achieves the goal and is able to intubate the cecum. Sometimes the trainer may give the trainee feedback in terms of how he achieved it. But this is where the concept of conscious competence comes in. If you are conscious and if you are aware of what the problem is, you have a good understanding of your image guide or your scope guide or your scope pilot, whatever system you're using, you are essentially able to talk the trainee through the procedure by directing him with certain techniques and specifically giving him what he needs to overcome the situation. So this is a valuable tool for both trainers and for trainees. And I urge you, if you're training in endoscopy, ask yourself those questions every time you get stuck, but not just that, every time you do any sort of endoscopic procedure. So how do we develop consciousness? It's through questioning, by asking those questions I showed you, by deconstruction, debriefing, by having good interpretation of your imager. Sometimes fresh eyes or scoping with someone new helps you develop it. Language is crucial. If you're able to express the feel in words, you're able to take a trainee through the process of reaching the cecum. And we have to recognize our limitations. And this is important to develop conscious incompetence as well. So just an example of conscious competence, again, I think if we are able to understand what the colon, to visualize what the colon is like internally, to visualize what our scope is doing internally, to be able to interpret the scope guide, to be able to understand the effects of gravity, the effects of fluid, the effects of air, and conceptualize our external with our internal movements, I'm certain it will benefit everyone's colonoscopy. This is just one example. We've all reached the cecum, find a cecum full of fluid, suck the fluid, and this fluid just simply reaccumulated and we haven't adequately visualized it. So what to do in that instance? So what you need to do is turn your patient to the right lateral position. But what I want you to try and grasp is why? Why do we do that? So the cecum is a relatively medially lying organ in comparison to the relatively laterally lying ascending colon. So in the left lateral position, you can see, based on gravity, fluid tends to pool in the cecal pole and over the ileocecal valve. But when you turn your patient to the right, you can see the opposite effect happening with the fluid moving up the ascending colon. So the next concept is that technique matters. And I truly believe that technique is equal to outcomes. And I hope to illustrate this through some studies. So we all have read many studies about GI bleeding, and we know there's abundance of data, but all of the data focuses on timing of endoscopy, risk stratification, the use of PPIs, endoscopic classification, comorbidities of the patient. And you can see a whole host of studies looking at a whole variety of endoscopic modalities used to treat PIV. But the one variable that's not addressed in these studies is technique, experience, training, and trainer's competence at training. It doesn't, to me, having the newest modality or a whole host of modalities, your modality of therapy is only effective if you're able to execute it correctly. And this is where training and technique comes into play. So if you look at some of these studies, you can see that rebleeding rates has been shown to be a measure, or experience of endoscopists has been shown to affect rebleeding rates, with endoscopists with less than and more than 2 years of experience having different rates of rebleeding. And again, you can see a similar study done in 2005, surgeons experience. So surgeons who have low volume experience have higher rates of rebleeding, higher number of blood transfusions, higher need for surgery. But it's not just about experience, it's also about quality of training. This is a study published in 2016. And in this study, you can see that there was no difference in rebleeding rates between registrars and consultants. However, the difference was these were senior registrars who were signed off to be independent endoscopists and were directly observed to be competent at managing bleeding. The next concept is a picture is worth 1,000 biopsies. And this is something I truly learned during my time at Belgium. And in order to take good pictures, you need to know your equipment. So you need to know the capabilities of your scope, whether you have near focus, any sort of image enhancement, the ability to use underwater imaging with near focus. If you have distal attachments such as a cap, you need to know your stack. But essentially, what is crucial before you take images, I urge you stand back and just take an overview of the issue at hand, the polyp, the Barrett lesion, and freeze your image. Just spend a few seconds and look at the freezed image and appreciate the lesion from afar before then going into targeted lesions and looking at, and when you take your pictures, try and include landmarks to make it easier for someone else to identify if you need to refer the lesion on. This is a concept that David has made me aware of. It's a concept of blink. It was introduced by Malcolm Gladwell in the book he published in 2005. And it essentially says that often our first impression is better than an overthought decision. And David has nicely shown in studies, which I'm sure are going to be published soon, that blink is a very effective tool at ruling out malignancy in polyps, and it can be trained. So this is just some practical examples I'd like to show you. So the problem with focusing and going into the polyp and then taking an image is you may get an image like this. And you may lose sight of the bigger picture because you may think that this is just an adenoma. You attempt to resect the adenoma. But when you step back, when you freeze your image, you can appreciate that this is actually a sessile serrated lesion with adenomatous tissue on top of it. So it's essentially a dysplastic SSL. And the key here is to remove the whole thing and not just the adenomatous component. This is another freezed image from afar. And you can see this is a Barrett's esophagus. And if you just look at it and spend a bit of time, if you notice carefully, you can see a little area of redness. And that's where you then should focus your efforts on. And when you get close up to that and you use image enhancing techniques like near focus, acetic acid, underwater imaging, you can see a clear demarcated, and this represented an early intramucosal cancer. Same with the last image, you can see a polyp on the fold. And if you just look at it from afar, you can already appreciate that there is some spontaneous bleeding. There's some extra redness. But if you look at the fold on the right-hand side, you can see it's slightly raised as compared to the fold on the left. And you get the impression that something is pulling this fold or tearing it down. If you look at it more closely, you see a clear demarcated area, and that represents a cancerous or malignant lesion. The other, one of the other techniques or valuable lessons I learned is the power of deconstruction. And this can be done via photo documentation or video documentation, video documentation being more ideal. And it allows conscious reflection in a less pressure environment where there aren't time constraints, where there is an anxiety and pressure to remove the polyp, where there aren't patient factors like pain, where there aren't trainer factors like a busy endoscopy list. And it allows you to use a very crucial and golden teaching aspect, and that's retrospection. So deconstruction is essentially the art of breaking something down. And it's useful to break procedures down so you can identify positives and reinforce it, but also so you can identify negatives and identify learning opportunities. What went wrong? Why did it go wrong? How can I prevent it from going wrong in the future? It also provides a platform to do assessments. And this provides you with a less biased assessment. Sometimes there may be disagreement between a trainee and a trainer. The trainee may say you closed the snare too early, or you may have misplaced the snare, and the trainee may disagree. But going through it in a video deconstruction afterwards leads to less bias and opens up, our concept and creates conscious unawareness or conscious incompetence. So just using the assessment tool, so Prof mentioned already KPIs. There are some other tools available like the cold snare polypectomy assessment tool published by Patel's group. And there's another tool as well, which is available at our disposal called the GPAT, or the Global Polypectomy Assessment Tool. This is a tool that was developed by David's team in the Ghent University Hospital and validated to show or be an effective score of polypectomy technique. So at this stage, I'd just like to take you through a video which illustrates some of the examples which I've been trying to show to you quite nicely. So I'm just going to change my screen share and take you through a video. So this is a video essentially of training that this is later on in my training, and this was an opportunity where I had to be the trainer. And this is a deconstruction of a video where I assess the trainer, but where I get assessed as the, where I assess the trainee, sorry, but also where I get assessed as the trainer. So let's just play some of the video due to time constraints. I'll just play some of the important points.
Okay, so firstly, I think it was quite a difficult follow-up. I mean, it was an SMSA pass follow-up to take. The access wasn't easy, it was overcome, so it was not an easy follow-up to begin with. Just to go through some of the aspects of the GPAT, I think we had quite a long discussion regarding choice of technique and hot versus cold and block versus piecemeal. I think there was no issues there. You chose the correct techniques all the time. The one thing that I think we both probably all agree on is whether we fully appreciated the extent of follow-up. And the back end or the anal end, oral end, sorry, was probably a bit more than I think either of us anticipated. We did make mention of fully appreciating it. We did look behind the phone to try, but I think it was difficult to fully appreciate it as well, given that it was typed over the phone. It was not too easy to get behind there. So that could have maybe been a bit more meticulous about appreciating the extent of the follow-up. The rest in terms of choice of technique, I think was good. Positioning with respect to the follow-up. So, I mean, it was not an easy position. You did try at sometimes certain stages to get it down to 6 o'clock, but it wasn't easy to maintain that position and to keep it on the right side. So I think the position was good, given that it wasn't easy to access. Yeah, so I think global competencies were fine. In terms of depth control, we didn't get good snare depth, which would have been a good measure of that. But I think it's fair. So then if you want to look at the first snare placement in the first injection, and then we see it's just on the line. Okay, so let's just get, okay, so that's the first probably injection. So we decided on an inject and reset strategy, and that we just inject enough for the first piece and then take it from there. Okay, so you did, I think the first point is this first injection, and it worked fine, but I think it worked fine because the lesion was quite bulky, but you didn't quite stay and pull back. You just kept pushing forward, if anything, and it actually drove your scope a little bit back. So there you were injecting before, which was fine, and then you kept on driving the catheter forward. I think you got away with it because the lesion is bulky, so it was easier to find. You went through the polyps, so it was easy to find the submucosal of pain, but just stabbing and pulling back there. And then you did pull back afterwards, and you did dynamically do it afterwards, and it gave a good effect. It achieved what you needed to. You were looking at the back end to see if there was enough there, just to have an idea of where you're going to place your first snare. I think it was good, but
I'm just going to skip forward to the first or one of the snare places, which I think is Thrive's own important teaching point.
The snare then inevitably becomes an issue in functional visualization.
It may be that you need to suck it out, but this is worth commenting on. What did you think of this as a trainer?
Yeah, so I think it wasn't easy to achieve that position. I just don't see where you ended up finally placing the snare, because I think we were having this discussion quite a bit.
Yeah, so that's how it closed. I remember watching it. What do you think about? What do you all think about that?
Yeah, I mean, it wasn't ideal. That again, like you're saying, the cut edge of the margin and the snare did shift a little bit closer. The V did move a little bit upwards.
Let's be clear to what we're saying, and maybe it's still illustrated. So what we're saying is that this, let's see something. It's not a great view, but there's the effect on the snare line is here, and the other snare line is here. So the V is not very open. That's the first thing. So maybe not so much tissue will come in. When I mean open, I mean that the angle is not more like this. Also, the amount of normal is unacceptably small, I think. And then when you watch it, as Bikesh says, as you close, you let it even slip more. So this I think it's unstable, right?
Yeah.
That's the first thing. You do have a little bit, you do have a tiny bit here, but you kind of want that wire to be here. So the left wire should be here, and the right wire should be somewhere you're compressing it. So if you have a big bit, like you did on the first one was excellent.
Yeah.
Because then you will avoid what happens here, where you're no longer sure that there's no other photon ones here. Everything's hidden behind this big mountain of over injection, which you can have removed maybe up front. And then I don't know what happens after that. I mean, you do get a nice piece, and maybe you cut it off. But maybe I found some residual on this edge. You can see look how messy that edge is, right? So the reason that edge is messy, look at this edge. You did this, right? So,
Okay, so I'm just going to skip forward to some of the trainer aspects where I get deconstructed as a trainer.
this, and did you have the feeling that you were, there's lots of different types of training on there. There's the sit back and wait and see how it's going, and or there's the totally say everything the person needs to do and essentially coach them. And which one do you think you were doing?
I think it was more on the side of talking a lot more than talking a lot less. I think it was more on the side of coaching a bit more than.
Did you feel that was appropriate for you? Did you feel that was useful? That you liked it?
I liked it. I did. You said it, and I did it. I didn't need to think by myself. A little bit maybe, but you told me no, I should do that, and I replace it.
And so what she's saying is that you have adapted. I think you've adapted your style to Celine. That's important, and you have correctly adapted your style to Celine, because Celine obviously liked, appreciated the tips, wanted it, but someone else maybe wants a different style. And so I think you have a very nice ability to, like, you clearly, are you consciously conscious of the procedure? Definitely. Do you know how to explain to someone how to do something? When, how to get your knowledge into their fingers? Definitely you do. I mean, I watch you, and I think that you really, really are very good at that. The question is that right for everybody? Probably not. But I think I've not seen you training in another situation, but I think that you will just need to find a way with that, because some people will like that, and other people will be intimidated by that or put off by that. And sometimes, not in Celine's case, but you need to sit back and just watch it. And I didn't feel like you did that, although I do think that the way that you did it was.
Okay, so I'm just going to take you back to my presentation now. Okay, so you can see there's really power in deconstruction. So the next aspect of the talk is knowing your limitations. And again, this is the function of consciousness and assessment tools, and it's directly equal to patient outcomes. But more than just that, it also enables us to identify areas of personal development. And again, we don't know what we don't know. And we need to identify that as a first point to begin and to enable us to get better. So what are some of the tools, and again, practical examples of illustrating this point? This is the SMSA score. So this is a score which assesses the difficulty of polyps. It's based on the size, morphology, the site, and the access of the polyp. There's then a SMSA plus score, which dictates what makes polypectomy very difficult. And either of these parameters, you just need one of them to make it an SMSA plus polyp. So it's again, size, difficult location, non-lifting, and granularity. And the SMSA score has been validated to predict outcomes in polypectomy. So you can see SMSA 2 polyps, shorter procedure times. As you get more complex, longer procedure times, less likelihood of success, and most importantly, more adverse events. So this is towards the end of my talk, and I want to emphasize that there's quality, there's endoscopy, and then there's quality endoscopy. And we should be focusing on quality rather than quantity. And I believe this is the way we prevent post-colonoscopy colorectal cancers and post-gastroscopy upper GI cancers. So if you look at some data again from the UK, from Anderson's group, it was a retrospective analysis of post-polypectomy, post-colonoscopy colorectal cancers. And they analyzed these colorectal cancers according to WHO classification or system of analysis. And you can see the majority of post-colonoscopy colorectal cancers were deemed avoidable, and the majority were affected by technical endoscopic factors. What's concerning is, if you look on the right-hand side, that about a third of these cancers are missed lesions in examinations which were deemed adequate. So that certainly points to technique being fundamental. And a similar concept applies to upper GI cancers. This is a study from a registry done in Poland, and you can see that 6% of upper GI cancers had an upper GI endoscopy within 6 to 36 months. This may not sound like a lot, but essentially 1 in 20 cancers had an endoscopy within 6 to 36 months. And that's certainly an area that we need to work on further as well. So just to drive the concept of quality, I'm just going to take you back and change my screen onto just to some videos. And these are videos taken directly off the Geeks website. So this is a lesion in the esophagus, and I'm just going to play it for you.
Easy, fast. So just going to come back to the fact that if you're going to go straight down in the esophagus to the stomach to check for the varices, like you might want to do in a patient like this, you go too quick, no insufflation, right? So many people do it like this. And then you have you check and say, oh, this looks nice, there's no varices. So we check that, we clean everything. But now we're going to do the same with sufficient insufflation, right? So basically the esophagus was collapsed. So, I mean, we can talk about characterization in a minute, but that's very, well, expert level and when you're deciding on doing therapy or not. But now look, we're going to do the same with a slow withdrawal. And we come by a lesion we definitely passed on the insertion. And now you clearly see something, right? So this should draw your attention. You can see the difference in color pattern, even with white light, that something is there. And very often people report this as candida, right? So that's a common mistake. And I think we should use.
I'm just going to skip forward so you can take a closer look at this lesion and see what we actually could have potentially missed.
You can you go a bit more into the sort of important line between what's okay and what's not okay in terms of IPCLs?
Yeah, so we do that again. So here it's clear, right? So you can see that you have this darker area. So that's how you pick this up with BLI. It looks darker, right? So that's the blink.
I'm going to stop the video there, but the point is this is an early squamous cell cancer, and this lesion was detected and was removed endoscopically via ESD, achieving an R0 resection. And I'm pretty certain that a large number of endoscopists would miss this lesion. So again, emphasizing the impact of quality. I just got one more video to show you, and this time we're going to colonoscopy and illustrating the same or similar example.
Probably got time for one more, and so it should be this one. So the first thing you should think when you look at this is, my God, if he's about to show cancer, I've missed a lot of cancer. So I thought the same when I first saw this one. I got called into a room actually to see this polyp, and the only thing that the person had seen, this is 180 generation imaging, so 2 generations older, maybe even 3 if you count that they've now got 2 generations in 1 generation. So it's old endoscopic imaging technology, and the only thing that the person that detected this had seen was what you see here. So have you got some comment on that, Vikash? Because it was someone younger than you that detected it.
So what draws your attention is the chicken skin mucosa, and that stands out and kind of urges you to have a second look at things and make sure you haven't missed anything.
Yeah, you can only be, I mean, you can only worry the number of things you've missed when you look at something like this, can't you? But anyway, you can also only be.
Again, I'm just going to skip forward and just show you a closer look at this lesion so you can actually see what it was. And there's a great example of chromoendoscopy here as well.
Vascular pattern. And then what we see here, for clarity and brevity, is we see the beautiful normal pattern of the standard polyp. We see a demarcation zone here. And at the bottom, there's a demarcation zone, which is regularly irregular. And at the top, there is a demarcation zone, which has completely lost all structure and is ulcerated. So we have here 2 demarcation zones, one of Kudo type 5I, but in our language, what we're calling regularly irregular, and at the top, a completely irregular, and what we're calling irregularly irregular. And therefore, this polyp is probably deeply submucosally invasive. And when we actually look at the pathology.
So the point that I'm trying to drive here again is that there is quality endoscopy and there's endoscopy. And the point that what we should be achieving is picking up, or what we should be aiming for is picking up these early lesions, rather than simply picking up the big cancer when the patient has an obstructive symptoms already and it's probably metastatic, and probably we've missed an opportunity for therapy. So that's the bulk of my talk. If we have a bit of time, I see, Prof, that David Tate is online, and if he's available, it would be a great honor to introduce him to the audience and perhaps get some feedback from him. David, are you there?
David, please go ahead. Please go ahead. You want to stop your share, probably, I think. And then we can, in the interest of time. David, are you there? Please.
Yeah, I'm here. Hey, I'm
please,
here.
Please unmask yourself. Nice to see you. Thanks very much for participating and
no, you're very welcome.
Yes.
Thanks for your time. I'm sure you in between 5 different things and a lot of.
I am in between, but it's very loud in here, so I'll just step out of it. Yeah.
We do appreciate your input. Perhaps you could add to some of the discussion.
Yeah, well, I mean, yeah, you've used that very nice case that we did, and I think it illustrates nicely some of the points that you've made. I really think, Vikash, that the message you have is a strong one. It's an important one. and it's one that needs to be out there. That I liked your slides. I mean, you probably knew I would like them. Your slides about quality, not quantity. I like your tips for training. I like your ability to interact with a trainee and a trainer. And I mean, what I really think is very important is that we do the basics well. And I think you put that message across very nicely. So yeah, for me, that's a strong message. And you introduced the platform. We very much we'll work with you guys, and I know you'll be the link. But we want to hear what the South African community of gastroenterologists want from an endoscopy platform. And if you have ideas, you just let us know, drop us mails. We're always making content, as Vikash knows, so we can probably make you something bespoke if that's what you want.
Thanks, David.
Thanks very much, David. You know, again, sort of myself having bought into the sort of whole JAG concept and being sort of inducted by John Anderson a few years ago, we very much certainly in our unit believe in the principles that are being expounded. And I think you know, the participation in your geeks, again, I think now that we can see exactly what goes on in geeks and the type of training that goes on, and I think it's a valuable tool for us to interact with you in Africa and take it forward in different ways. Hopefully I'm recruiting Vikash, and maybe we can sort of sort out some of his cognitive overload tendencies when we're training a little bit in Namibia. So hopefully we'll have a good session there. But again, we're really focusing on basics. And again, one of the other things which is problematic for us is bowel prep within the state sector. And I think that's also local problems that really need to be addressed, because it's really, you can have all the fancy kit in the world, but if you don't have good bowel prep, then things are really...
Well, I think, Sandy, you can have all the fancy kit in the world, and maybe we have it, and maybe some people are less lucky, but you can also have all the training in the world, and the bowel prep can be bad, and you still won't get anywhere. So I think that's also important to say. Absolutely. Yes. So these things are very important.
Yes. So thank you very much for listening in. And
you're welcome.
There are a lot of questions from a colleague of mine in the Mass General called Acqui, and maybe some of them are related to how we take TTT into some of the African situations that she and I have been working. And I'm not sure if they're answerable by all of us, but I know Chris would like to address some of the funding issues. Or possible resources. Chris?
Yeah, thanks very much. Thanks, Sandy. Hello from Doha. So and hello, David. Thank you so much.
Hey, no, that's okay, Chris. Nice
it was good to see you at UGW. So GICS not only for South Africa, it's GICS for Sub-Saharan Africa. So we will be focusing on the whole of the subcontinent. Just some points as far as funding is concerned. I mean, Vikash, you tick all the boxes. Really, it's perseverance, 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 perseverance. And I think the second important thing is when someone comes to you and wants us to pay for everything, he's the wrong person. If you're paying totally for someone, it's the wrong person. It's called risk sharing, and when someone brings something to the table, even if it doesn't matter how small it is, we get very excited to add to it. So it's important when approaching institutions for funding that you at least attempt to bring something to the table so that we can all contribute and share in the risk. I think that's a very important concept. But I mean, we're very open, very, very generous, I think, and very keen to sponsor as many people as we can. And I think Vikash did an excellent job, and I'm sure he's going to drive this and be the conduit for us. So congratulations to all. I'm very excited by GICS, and thank you very much, Sandy.
So I think I really don't know if we've got time really to try and address these things. I'm happy to sort of try and address things personally with those who are on the call. And again, the sort of funding and the competence assessment are things that we need to work on. I do think there's also needs to be a culture of capture, that we need databases, and databases should be easy to run, even if they're not on fancy internet. We need data, and we need assessment data on how our trainees are doing. And I think that's perhaps something in South Africa that we can take forward with SAGES to make that more mandatory than it currently is. It's a sort of preferential thing amongst some of the units. So I think I'd like to just David, you want to just have a final word? And then
Well, just there, I see that comment about on the chat. I was just reading through the chat. I see that comment about how do we define competence. Did you answer that already? Vikash, you answered it a bit in your talk. Yes. I don't know, Sandie, I missed the first part of your talk. I don't know whether you answered it, but I think that from my point of view, we need competency frameworks for that, and we will come forward with them. So that's one of the Geek's main missions, is to come forward with competency frameworks. I know the JAG have done it very nicely for colonoscopy, but it's not really there for polypectomy. I think we have one because showed it, the GPAT, but I think we really need to invest time in those things. We really need to evidence-base them, and we need to be using them and seeing that they work, refining them, because I think this concept of quality over quantity is important, and therefore there should be no minimum number of procedures, right? I mean, if you're a surgeon and you're not performing to the required level and you're getting complications or whatever, then certainly in Belgium, you're not allowed to practice anymore. And that's just not the case. It's not even the case in Belgium or in the UK that you're doing polypectomy and you're doing it badly and you're not allowed to continue doing it, you know? So I think that there are real important things to be had via educating people. You know, everybody does things wrong. As you said, Sandie, no one's born a trainer, no one's born a polypectomist, no one's born a colonoscopist. And I think it's very important to acknowledge that and to see where people can improve. And really a competency framework is the way forward for that.
Thank you very much. We look forward to seeing how Geeks takes that forward. And we obviously have some own ideas, because we have a very low rate of advanced adenomas within the African population. So again, you can't get good at things if you don't have
that's very important. No case experience. Yeah. Okay, guys. Well, it was a pleasure. Very nice.
Thanks very much for participating, David, and taking the time out from your schedule.
Thanks, David.
Thanks, Chris. Thanks, Vikash.
Cheers, Dave. Thank you.
And thank you to all those who've posted there. As I say, I think in the essence of time, unless I think we've sort of sown the seeds that we should be doing more training. I'd just like to thank the whole setup that allows us to do this. The videos and this interaction is all taped, and it will be available on the Gastro Foundation website. And I'd just like to thank the sponsors who make it possible. And next week will be, I believe, pediatric gastroenterology. So for those of you who are interested in that, and to all the attendees, thanks for listening in. And we'll see you next year for the next endoscopy session. Thank you.
Thanks, Andy. Thanks, Vikash.
Thanks, Prof.